attending the session. I'm going to talk about how to interpret catheter angiography with a focus on normal anatomy and various pathological conditions. Okay, and on the upper left side, this is our homepage, and this is our hospital, which is located in Tokyo, in the center of Tokyo here. This is our hospital, and I'm working in at neurosurgery department. I do endovascular treatment. Okay, today I'd like to present several key topics. A main topic is how to interpret catheter angiography and on normal anatomy and circulation and understanding collateral circulation. And finally, we'll look at the pathological findings such as vessel occlusion, aneurysm, and AV shunt. Before entering main topic, I will mention, mention why catheter angiography is needed and the characteristics of catheter angiography and indication for catheter angiography. Okay, let's begin with the why catheter angiography or CA is needed. To answer this question, it is necessary to know the characteristics of catheter angiography and indication for catheter angiography. Okay, catheter angiography remains a gold standard due to its high spatial resolution to detect small vessels such as perforators or something. And it's also crucial for assessing hemodynamics of the lesions, like AV shunts or flow problems such as congestion. So, and when we plan endovascular treatment, preoperative assessment by catheter angiography is essential to construct treatment strategy. Okay. Catheter angiography is sometimes called as DSA, which means digital subtraction angiography. Here we subtract bone images from the initial digital angiography. The subtraction image results in a clear image. And on the right side, you can see the bone is removed and the clear images around the clips and some bone is visualized. Okay. Catheter angiography provides multiple types of imaging. One is 2D dimension DSA, and the other is 3D rotational angiography. And in 3D rotational angiography, there is a 3D image like this, and the other, we can obtain a cone beam CT, such as like this image, and those all can give us a full picture from anatomy to the treatment planning. Okay, 2D DSA gives us essential basic information with high spatial and temporal resolution. Due to its high spatial resolution, we can evaluate fine vessels like perforating arteries, like this, or information of vessel surface. And temporal information is crucial because hemodynamics is the key component to assess the vascular regions. So the 2D DSA is very important. Okay. 3D rotational angiography, which is obtained by serial acquisition of images during rotational movement of blood panels. And the reconstructed images provided us detailed morphological analysis of lesion surface and spatial relationship between the region and surrounding structures in 3 dimensions. This information can give us appropriate working angle or proper treatment strategy for endovascular treatment. There are 3 kinds of reconstructed images obtained from rotational angiography. One is volume rendering image, the other is translucent images, and the other is partial MIP cone beam CT images. Volume rendering images like this gives us important information on the 3D morphology precisely like this, and gives us an appropriate angle to treat the regions. The translucent images gives us about good information on overlapping structures like this from one direction. It enables us to evaluate it, such as aneurysm neck like this. And cone beam CT is partially reconstructed image slice in arbitrary axis, which is beneficial for evaluating very small vessels like this. Okay. Catheter angiography is indicated for various central nervous system vascular regions. These includes hemorrhagic diseases such as aneurysms or AV shunt disease, and ischemic lesions such as vessel occlusions or stenosis. And the other indications are traumatic vessel injury or hypervascular brain tumor. So in these cases, we do catheter angiography. Okay, now let's move on to the main topic, how to interpret catheter angiography. First, I will talk about the normal anatomy and cerebral circulations. Then I'll explain how to evaluate functional imaging, including dynamic aspects like this. Finally, we'll go over how to identify and interpret pathological findings. When interpreting catheter angiography, it's crucial to evaluate all time phases. Arterial, capillary, venous. The early phase means arterial phase, and the middle phase is capillary phase, and the late phase is venous phase. From detecting each phase provides different insights from arterial regions from arterial time phase and disturbed perfusion in capillary or venous phase. Okay, in the arterial phase, we observe the flow of contrast through the arteries, and this helps identify arterial lesions, such as aneurysms and vessel occlusions, or early venous drainage, which indicates the AV shunts. So this slide shows that the AP, anterior posterior view or frontal view of internal carotid artery angiogram. As you all know, that there is a ICA. This artery is ICA, internal carotid artery, and this artery is middle cerebral artery, and this artery is anterior cerebral arteries. In the lateral view, you can see the internal carotid artery like this, and the first branch of intercranial portion is ophthalmic artery, and the second branch is posterior communicating arteries like this. Next is a capillary phase. This reflects tissue perfusion. We look for perfusion defects, venous congestions, and abnormal capillary pattern that may suggest pathology. In the venous phase, we assess venous drainage. This slide shows the typical venous structures, including dural sinus system in the anterior view, the superior sagittal sinus and transverse sinus and the sigmoid sinus. In the lateral view, this is the superior sagittal sinus, this is transverse sinus, and this is sigmoid sinus. For the deep venous system on the lateral view, you can see that this is internal cerebral vein, this is a vein of Galen, and this is straight sinus. And surface main cortical veins is like this. This is vein of Labe is here, and superficial middle cerebral vein is here, and vein of Trulalo is here. These are anasmosing each other. So from now on, we'll present normal vascular anatomy in order of 6 vessel study. At first, we check the puncture site and then evaluate the access route at the neck and chest level at brachiocephalic and subclavian artery. And finally, we acquire images of cranial vessels Six vessel means that the bilateral internal carotid artery and external carotid artery and vertebral artery, they are six vessels. So that's why we called it six vessel study. Okay, uh, I'll talk about the puncture site. Classically, transfemoral approach was the mainstream of catheter angiography. On the left side, you can see the anatomy of transfemoral approach. A deep femoral artery and superficial femoral artery merges to form the common femoral artery, continuous to external iliac artery and common iliac artery. And the most popular puncture site for cerebral angiography is common femoral artery at the level of head of femoral bone. Here's the puncture site. Okay, recently radial artery puncture is also become popular, as shown in the right side of slide. You can punctate the radial artery, and you can find the ulnar artery, and there is anastomosis between them on the end. Okay, before introducing my catheter into cervical arches, we check at first the branches of aortic arch. We place the catheter at the origin of brachiocephalic artery to see the subclavian artery and the origin of vertebral artery and the right side common carotid artery. We check on the right side this. Then after that, we check the left side, left subclavian artery is here, and the origin of left vertebral artery is coming from here, and you can see the thyrocervical trunk and just distal to the origin of vertebral artery. Also, you can see the course of common left side common carotid artery like this. Okay, then we place the catheter within the common carotid artery here, and we check the cervical portion of ECA, ICA, and common carotid artery. This is a lateral view of common carotid artery injection. You can find the internal carotid artery is posterior to the external carotid artery, and the frontal view in ICA is medial to the ECA. It's like this. Okay, so I'm going to show you the vascular anatomy obtained from internal carotid artery. The ICA is divided into several segments, cervical segments, petrous segments, cavernous segments, and supracrinoid segment. One popular definition of ICA segment in my country is shown in this slide like this. C1 refers to the portion from the top of IC and to the original posterior communicating artery refers to C1. And C2 is from original PCOM and origin to the origin of ophthalmic artery. This is C2 segment. And C3 is GNU of the ICA, and C4 refers to cavernous portion of ICA. C5 means the petrous portion of ICA, and after that, cervical portion is here. So we called C1 or C2, C3 to call the segment of ICA. And anterior cerebral artery is running mainly in the interhemispheric fissure and supplies a main portion of frontal lobe and parietal lobe. And SCA is labeled from A1 to A5. A1 refers to this portion from the top of the internal carotid artery and the original to the anterior communicating artery here. And the A2 is a post anterior communicating artery segment here and below the corpus callosum. And A3 portion refers to the pre-callosal area and frontal side of callosal artery, corpus callosum. And A4 refers to supracallosal segment, this is here and here. And A5 is postcallosal segment. Yeah, yeah. Yeah. And also you can see there are some cortical branches of anterocerebral artery. This is prefrontal artery. This is paracentral artery. It is internal parietal artery. This is the anatomy of anterocerebral artery. Then I'd like to talk about middle cerebral artery, MCA. The MCA rises from the top of the ICA here, running laterally through the sylvian fissure and bifurcates or trifurcates into distal branch and running on the surface of insula and sorry, and operculum here, and finally it is divided into several cortical branches. So the MCA is consisted of four segments, M1, M2, M3, and M4. M1 refers to the horizontal segment of the MCA, and M2 is post bifurcation, trifurcation, and insular segment here. M3 is opercular segment, yeah, and M4 refers to the cortical branches. So this is the MCA anatomy. Okay, and then we move on to external carotid angiography. Okay, the ECA has several branches at the cervical level, like this slide. And, number one, this is a main trunk of external carotid artery. This is lateral view, and this is ICA. And the number two is facial artery here. Number three is running like this. It is lingual or artery to the tongue, supplying tongue. Number four is occipital artery, is coming from the posterior wall of ACA and go to posteriorly. And number five is this is ascending pharyngeal artery. It is very important artery, which in many cases which is originates from the origin of ECA, but in sometimes it originates from the posterior occipital artery or some other arteries. And this is very dilated in this film because of the vascular regions of the head. And the number six is the superior thyroid artery. These are the cervical branches of ECA. Then this slide shows the branches of ECA in the cranial portion. Number one is also ECA main trunk. Number two is the occipital artery. And ECA and finally, it divides into two main branches. One is number three, internal maxillary artery, and the other is number four, or superficial temporal artery. These are the final branches of ECA. And from internal maxillary artery, you can see the middle meningeal artery here. And you can see the posterior auricular artery here, which is supplying the skin posterior to the ear. Okay, this slide shows the anterior posterior view of external carotid artery. And number one is ECA main trunk. Number two goes superficially. This is superficial temporal artery. Number three runs within the skull at the edge of the temporal bone, which is the middle meningeal artery. Okay, then I go to vertebral angiography. Okay. The vertebral artery give rise to pica, a posterior inferior cerebral artery, and both of vertebral artery joins to form a basilar artery. And basilar artery runs anterior to the brainstem here, and then branches into posterior cerebral artery, PCA. And basilar artery give rise to perforating artery here and superior cerebral artery and anterior inferior cerebral artery. Okay, I'll talk about the posterior cerebral artery anatomy. This is PCA, and PCA supplies mainly occipital lobe and parts of temporal lobe mainly. And PCA is divided into four segments, P1 through P4 segments. And P1 is defined as segment from the top of the basilar artery and to the junction on posterior communicating artery and PCA here, red triangle here. And P2 refers to portion of quadrigeminal, ambient cistern. And A means anterior, P means posterior. So ambient cistern, anterior portion, and posterior portion. P3 refers to the quadrigeminal cistern, and P4 is the cortical branches. And we can evaluate the PCA both in vertebral angiography and internal cerebral angiography. So in the ICAZ, the first branch from the ICA is PCOM, and red, this is the transition to the PCOM to PCA, and this vessel is same as this one. On the right side, two main cortical branches, which is very important, and the parieto-occipital artery and the calcarine artery, which is supplying the visual cortex, it can be identified. And also, you can see the medial posterior choroidal artery here and the lateral posterior choroidal artery here. Okay, these are cerebral arteries, very simple. On the first branch below the PCA is a superior cerebral artery. SCA is supplying the superior surface of cerebellum, and the anterior inferior cerebral artery ICA is coming from the trunk of basilar artery here and goes to CP angle and the medial part of supplying medial part of cerebellum. Pica is coming from mainly a vertebral artery in many cases and supplies the posterior inferior surface of cerebellum. Okay, then I would like to mention about some clinical important vessels of branches of ICA and ECA. I will talk about the anterior choroidal artery and intermaxillary artery, middle meningeal artery, and ascending pharyngeal artery, and vessels supplying cranial nerves. Okay, the anterior choroidal artery is very important vessels that supplies critical deep structures, including the posterior limb of internal capsule and optic tract, and the lateral geniculate body, and choroidal plexus of lateral ventricle. And anterior choroidal artery syndrome, which is caused by the occlusion of anterior choroidal artery, is characterized by the triad of symptoms, hemiplegia and hemisensory loss and homonymous hemianopia. So that's why it is very important to know the anatomy of cause of anterior communicating artery precisely. On the frontal angiographic image here, you can find the anterior choroidal artery. So can you see the anterior choroidal artery? And the white triangle shows the anterior choroidal artery. The origin of anterior choroidal artery is from the C1 segment of ICA here, and then curves. At first, it goes medially and goes superiorly and laterally, it forming a characteristic upward curve like this. This is the course of anterior communicating anterior choroidal artery. Then I'd like to talk about the plexal point. It's one of the most important anatomical landmark. Because the anterior choroidal artery supplies vital structures such as optic tract or pyramidal tract before the plexal point. Here is the plexal point. And beyond the plexal point, it supplies only choroid plexus So that cannot be a cause of severe symptoms beyond this point. So you can find the plexal point in the lateral angiography, and here, this is the plexal point. And this case is lat- mm, parietal lobe arteriovenous malformation with a large barrix, or a large aneurysm here, and which is supplied by posterior choroidal artery, but it is also supplied from the anterior choroidal artery. In this case, this is a internal carotid artery, and this is anterior choroidal artery. And this anterior choroidal artery gives branches to the aneurysm. So if we want to treat this aneurysm, then we inject the NBCA glue from this artery. We have to go beyond the plexus point here. So in this case, we can finally go beyond the plexus point, so we can occlude the aneurysm without any complications. So this the plexus point is very important in anterior choroidal artery. So then I'd like to go to the internal maxillary artery. IMA is divided into mandibular portion and zygomatic portion and pterygopalatine portion, three portions. And from the proximal side, IMA branches some important vessels. One is middle meningeal artery here, and the other is accessory meningeal here. The other is middle, middle deep temporal artery here. And this is the more distal portion, pterygopalatine segment of internal maxillary artery here. You can see the infraorbital artery. And this is the sphenopalatine artery, which is supplying the nasal mucosa. And this is descending palatine and greater palatine artery, which is supplying the hard palate or something, oral cavity. So okay, then I'd like to talk about the middle meningeal artery branches. And uh, middle meningeal artery comes from the internal maxillary artery, go upward and go through the foramen spinosum and make a turn to go anteriorly and make two branches. One is the anterior branch of middle meningeal artery. The other is the posterior convexity branch, number 2 here. And at the level of foramen spinosum, there is another branch, a petrosquamous branch, which is the surface of the squamous bone. And you can, in this film, petrous branch is not depicted, but there is a one branch to the petrous bone. Okay, ascending pharyngeal artery. And this is also a very important vessel that supplies the pharynx and lower cranial nerves. There is two main branches. One is a pharyngeal branch, and the other is neuromeningeal branch. In the anterior frontal view, the number one is here is pharyngeal branch. Number two, sorry, in the lateral view, you can see the pharyngeal branch go anteriorly. And the number two is neuromeningeal branches, which is divided into two more branches, jugular foramen branches and hypoglossal canal branches. This From this film, you can see this is ascending pharyngeal neuromeningeal branch, and go medial. This is running within the hypoglossal canal. So this is hypoglossal branches, or branch of ascending pharyngeal artery. And number 2A goes more posterolaterally here, is the jugular branch of neuromeningeal branches. And this is the cone beam CT from the 3D angiography of ascending pharyngeal artery. This is ascending main trunk ascending pharyngeal artery, and it goes medially, goes through the hypoglossal canal. This is hypoglossal branch. And the other branch here goes laterally and go upward and finally go into jugular foramen. So this is jugular branch of ascending pharyngeal artery. Okay, here I'd like to discuss the vessels that pass through the foramina of skull base, like this. Most of these foramen transmit cranial nerves, like this. And sometimes they play a very important role as the anastomosis between external carotid artery and internal carotid artery system. So this is very important. So it's essential to have a solid knowledge about the vessel that pass through the foramen of skull base. So then I'd like to show you these foramen and vessels. This purple circle means uh, foramen rotundum. So the V2 maxillary nerves go through the foramen rotundum, and artery is coming from here as phenopalatin artery to give rise to artery of foramen rotundum. This one. Okay, then the blue circle refers to the V3 mandibular nerve here. And mandibular nerve is running here, and this is foramen ovale, which contains the mandibular nerve and accessory meningeal artery, AMA, from the one of the branches of IMA here. Okay, as I said before, the green circle means foramen spinosum that contains the middle meningeal artery, and the orange circle here is the hypoglossal, and this is ascending pharyngeal artery. This is the hypoglossal canal here, and pink circle means the jugular foramen, and cranial nerve, lower cranial nerve run through it, and the ascending pharyngeal artery is running within the jugular foramen. So these cranial skull base foramen and artery and nerves we should remember. Okay. Vascular supply of facial nerve is also important. Several vessels, such as petrosal artery of middle meningeal artery and internal auditory artery from ICA and stylomastoid artery from occipital artery, anastomos within the facial canal, and all supply the facial nerves. And so it makes this curve. So this is called facial nerve arcade. This is very important structure that we should know to in order to avoid the facial nerve palsy. Okay, from now I'd like to talk about the evaluation of collateral circulation. So as you all know that the circle of Willis is very essential in maintaining collateral form. As you can see, this is visual artery at PCA and PCOM, ICA, A1, ACOM, and this is making a circle of Willis. And however, individual variations of this development of circle of Willis can affect how well a patient tolerates for arterial occlusion of uh, this segment. Thus, the technique using temporary vessel occlusion helps us evaluate these pathways during angiography. Matas test means the internal carotid angiography during temporal occlusion by manual compression of contralateral ICA, CCA. This test tries to reveal whether anterior communicating artery is functional or not as collateral pathway. This uh, during flow arrest of contralateral ICA. So we occlude the CCA and inject from contralateral side, and we see we should check the difference of arterial and capillary opacification between two hemispheres. And this is a Matas test. Alcock test is also important, which is the vertebral angiography and the manual compression of internal carotid artery. In this slide, on the left carotid artery compression, vertebral angiography demonstrates the opacification of left internal carotid artery here through via the posterior communicating artery. So in this case, posterior communicating artery is functional and patent, and that can supply enough blood to the anterior circulation from the vaginal artery and the compression and the occlusion of ICA. The BOT, balloon occlusion test, is another method to evaluate collateral circulation. While occluding ICA, with the balloon, we assess back pressure of ICA distal to the balloon and cortical oxygenation, this is the probe, and it can be measured by near-infrared spectroscopy as well as neurological symptoms. So it helps to determine whether collateral flow is sufficient during temporary or permanent vessel occlusion. So in this case, the patient has carotid body tumor on the CCA, ECIC bifurcation, and we check the tolerance of temporary occlusion by ICA by balloon. Okay. Okay, this slide shows the images during carotid artery stenting and distal ICA occlusion, balloon occlusion. As you can see, this is the stenosis side, and we advanced the balloon catheter here and dilate the balloon to occlude ICA in order to protect the distal embolism. So under this occlusion, we inject the contrast, and ICA is completely occluded, and ECA is opacified. In the third and fourth from the right film here, you can see the opacification of distal ICA here. So how do we interpret this phenomenon? Okay, the answer is potential anastomosis of ECA and ICA in this situation. And the collateral flow from ECA empties into distal ICA. This film I support. So I show the schema of the anastomosis of ECA and ICA through ophthalmic artery. Anterior branches of a middle meningeal artery give rise to recurrent artery, meningeal artery, as shown here, and it goes through the superior orbital fissure or lacrimal foramen to anastomose with the branch of ophthalmic artery here. And from ECA through this anastomosis to the ophthalmic artery and to ICA. So that's why when we occlude the ICA, sometimes contrast or blood flow goes from ECA through the ophthalmic artery to ICA. This is the interpretation of the previous image. Okay. Then I'd like to go to pathological condition. On the right side, this pie chart shows the breakdown of my experience of endovascular treatment. I treat 40% aneurysm, 20% AV shunt, and 30% is ischemic region, and 10% tumor embolization. So for endovascular treatment interventionalist, we should know the pathological findings, including vessel occlusion, aneurysm, and AV shunt, and tumor, and other. So I will show you briefly the representative cases. So here we observe vessel occlusion cases. Identifying which vessel is occluded is critical in acute stroke. So this is very easy. This is a 67-year-old male with consciousness disturbance and right hemiparesis, and the MR angiography shows like this. And left side internal carotid angiography shows this film. So which is where is the occlusion site? As you know that the internal carotid artery is occluded. So where is the occlusion site of ICA? The answer is C1 portion here, and this branch is anterior choroidal artery. So the occluded site is just distal to the anterior choroidal origin. So we move to next case. So which vessel is occluded? Which is very easy. And you can see that the MCA is occluded here, so the M1 occlusion. And this patient has recovered after the thrombectomy of M1 thrombus. Okay, how about this case? This patient has also motor aphasia and right hemiparesis. This is anterior view, frontal view of left internal carotid artery. As you can see there, you can see the ICA is patent, and anterior cerebral artery is also patent, and the middle cerebral artery, and M1 is patent, M2, M3, you can find several vessels. So where's the occluded site? Patient has very severe symptoms. So in this case, we should see the lateral view, of course. So what is the problem in this case? So we should follow the course of main trunk of MCA, ACA, and also we should see the perfusion defect, filling defect. As you can see, there is a filling defect, like triangle, or like this, and on top of the triangle is the site of arterial occlusion. So this is the occlusion site. So the M2 occlusion is the diagnosis of this case. Okay, stenotic lesions can occur in carotid artery and subclavian artery in the intracranial arteries. And this is a right lateral view of common carotid artery, which shows that the stenosis of internal carotid artery here. This is plaque, and in this film, from this pathology, and thrombus go in the brain and makes A2A embolism like this. And how about this case? And this case is 69-year-old female with recurrent stroke under medication, full medication, dual antiplatelet therapy. And this case also has a recurrent stroke, even after administration of antiplatelet treatment. So, and you can see that there is a bulging and protrusion of vessel wall into the internal carotid artery. So it may be a cause, but it is not severe, and these patients are fully medicated, but they have still recurrent stroke. And this phenomenon is called one special situation. The diagnosis is the carotid web. The carotid web is not atherosclerotic lesion like internal carotid artery stenosis, but this is one of the fibromuscular dysplasia, and one hard protrusion makes the blood stasis here and make a thrombus, and the recurrent stroke happens. So it is very similar but distinct pathology from the ordinary typical internal carotid artery stenosis. So in this case, this signs very triangle protrusion is the key to find the carotid web. And This case is presented with vertigo, but there is no severe infarction, and MR angiography shows the disappearance of vertebral artery. The MR angiography does not reveal the stenotic segment, but the 3D angiography clearly shows the stenotic regions. So that's why we need the angiography, and we do a balloon angioplasty to recover this flow. Okay. This case is cerebral infarction in insular cortex. And MR angiography is suspected, an M2 occlusion is suspected. But when we do the catheter angiography, there is no apparent M2 occlusion. So what happens to this case? So, but when we see the more in detail, you can see the contrast media is a little bit make stasis here. So the vessel wall of M2 segment is dissected. So the dissection of M2 segment, insular segment, is the diagnosis of this case. You cannot diagnose by CT angio or MR angio for this very small this dissection, but digital catheter angiography can reveal this pathology. And this is another very rare disease I can show you. And there is a stenosis of ICA. This is a frontal view of internal carotid artery. There is stenosis here. The lateral view, there's stenosis here. And you can see these characteristic vessels like this. This is the perforating arteries. This disease is called moyamoya disease, and in East Asia there are so many patients. And main pathology of this disease is the stenosis of the terminal portion of internal carotid artery, and this stenosis gives rise to the also occlusion of MCA and ICA, and so instead, the collateral pathway via the perforating arteries developed. And this perforating artery may can become dilated, so we can find this characteristic findings. Artery stenosis at the terminal ICA and perforating artery dilatation is the main characteristics of Moyamoya disease. Okay. And I mentioned a little bit about the cerebral aneurysm. We classify the aneurysms such as circular, fusiform, and dissecting. This is the typical circular aneurysms. So we describe the aneurysms by its location. For example, this is the aneurysm located at the anterior communicating artery, so we call it ACOM aneurysm. And this is the aneurysm, circular aneurysm, located at the pica origin of vertebral artery. So VA pica aneurysm, we call it. And sometimes we encounter not circular aneurysm. This is the bleeding patient, and vertebral angiography reveals the dilatation of vertebral artery itself, and there is a protrusion, like as we call it, gleb, is found. So this is the dissection of aneurysm, vertebral artery, and this pathology involves the whole entire segment of artery. So we have, when we treat this case, we should occlude this dissection part totally, and so we have to sacrifice this vessel. So in this case, we have to evaluate the contralateral vertebral artery circulation. And in this case, this contralateral VA vertebral artery is supplying the basilar and PCA and enough flow volume, so we can sacrifice this region. Okay, how about this? This patient has severe subarachnoid hemorrhage, and there's no vessel abnormalities rather, at the left side of vertebral artery angiogram. On the right side, internal carotid angiography is like this. This frontal view, and this is lateral view. So the only one point of the abnormal findings is here. Yes, here, very tiny protrusion of vessels. But we wait for several days. This aneurysm enlarges by time. So it means that this is the aneurysm, it's growing. And this type of aneurysm is called blood blister-like aneurysm, BBA, and which is caused by the dissection of internal cerebral artery. Uh, this is one BBA case. Okay, the time is coming. So, and in the treatment of aneurysm, the 3D image is very important. And in this case, we take the 3D image, translucent image, that we evaluate, in this case, we plan to coil embolization, and we have to evaluate this aneurysm. So in this film, we can find that the proximal neck the angle is very sharp, but the distal angle of the neck is very wide. So the distal side of the neck is the key to occlude the aneurysm by coils. So in this case, from the information of 3D angiography, we plan to make a wall by balloon to protect this distal neck. So in this case, we implant the balloon at the neck fully and place the coils, so coils like this. And this neck is very not occluded, so we finally put the coils by keeping this area closed by balloon, and we insert the small coils here, and finally we get a good result. Okay, so we have no time. So I'll just talk about the out-of-venous shunt, AVM, bio-AVF, and dual AVF. So what is the definition of AV shunt in catheter angiography? It is early venous filling in DSA. Early venous filling refers to the visualization of veins during arterial phase of catheter angiography, suggesting the presence of arteriovenous shunt that bypasses the capillary in the parenchyma. This is the angiography of the arteriovenous malformation in 2D dynamic images. You can see the arteriovenous malformation here. Okay, in this film, in the arterial phase, here there is only artery is shown, but the region, nidus and vein is opacified. So the early vein is observed. So the diagnosis is resulted in the AV shunt here. Okay, so 2D DSA dynamic images tell us the early venous filling for this case, and the 3D DSA images can give us the morphological information. There is a nidus here and internidal aneurysm we can see, and there is also a venous dilatation, which is called varix, is clearly seen by 3D angiography. Okay. This is one of the rare case, but we see sometimes in this case. This is a pial arteriovenous fistula. This is the dilated feeding artery makes a shunt here, and the draining vein is very dilated. Without, we cannot see any nidus. So, if direct AV shunt without nidus is called PIR AVF. These cases can be seen mainly in pediatric ages and congestive heart failure, and sometimes it leads to bleeding. And but the prevalence is very low, several percent of severe vascular malformation. Okay, then I'd like to talk about another type of AV shunt disease. This is dural arteriovenous fistula. I'll show you the dynamic image to the angiography. It's like this. Okay. You can see the middle meningeal artery here and occipital artery here and ascending pharyngeal and some other external carotid artery is coming to making a shunt here. This is a transverse sigmoid sinus. So the this is dural sinus. So the in the arterial phase you can see the vein, early venous filling. So it means there is a AV shunt on the dural sinus. So it means a dural arteriovenous fistula. And this venous drainage making stagnation of posterior side of temporal lobe, so it makes congestion. So we should treat this case. In this case, we advanced microcatheter in the middle meningeal artery and injecting LVCA to glue into the AV shunt site and penetrate the AV shunt and occlude the sinus and arteriovenous shunt, and many feeding arteries is occluded backward. So we can treat this case. Okay, the last case is trauma case. This is a 25-year-old traffic accident patient. He has severe nasal bleeding several times. So in this case, we checked the CT angiography and we find that the fracture of medial wall of orbita. And you can find the contrast stagnation here, and angiography showed the aneurysm at the distal portion of ophthalmic artery. In this case, we advanced the microcatheter to the ophthalmic internal carotid artery to the ophthalmic artery, and here we find this is the pseudo aneurysm at the anterior sigmoidal artery. So in this case, we inject the NVCA because it is ophthalmic artery, but the tip of the mitral catheter is very far from the central retinal artery, so we can inject and we treat this case. And nasal aneurysm has disappeared and no bleeding afterward. So I'm going to close this session with some cautions. And, catheter angiography is very valuable, but this DSA has still have some risks. The percentage is around 1%, 0.5 to 1%. Complication includes thromboembolism, distal dissection, allergy, and reader dysfunction, and puncture site syndrome or something. So we have to do very meticulous procedure, and the another thing of important thing is that the communication with the patient is very important. We should get high quality image. We should do safe imaging, and in this situation, patient cooperation is very important. We said we explain the patient what we should do, we are going to do, and uh, we make good, appropriate communication. So in this case, as a result, patient became the anxiety has disappeared and very cooperative, and still head is very stable position, and those factors can result in a good high quality images. So this is the very important things. So in summary, catheter angiography remains a cornerstone of neurovascular diagnosis and planning. Understanding both of the normal and pathological features enables better treatment decision. Okay, I'll finish my presentation. Thank you very much for your attention. Thank you very much.
Thank you very much. We are very happy to have such a fantastic lecture. I, on behalf of my organizing team, Pakistan Society of Neurosurgeons and Nishtar Medical University, Multan, Pakistan, very much thankful to you. Please keep connected in future as well.